Welcome to Muted in Medicine, the podcast where we break the silence on the untold stories and pressing issues within the healthcare profession. Join us as we dive deep into topics that often linger in the shadows of medical corridors and are not discussed in conferences, meetings, social gatherings, and in the hallways. They are often hiding. From navigating errors and facing litigation to the often overlooked realm of mental health among healthcare professionals. Through candid conversations and storytelling, we aim to amplify the voices and shed light on challenges that resonate across the medical landscape. So grab your stethoscope and a cup of coffee and tune in as we uncover the layers of complexity in the world of healthcare that are so muted yet so profoundly impactful.
Hello, everyone, and welcome to another episode of Muted in Medicine podcast. My name is Saba Fatima, and I'll be your host for this podcast. I'm a pediatrician with a passion for helping healthcare professionals facing secondary trauma at work in healthcare, which often they are unprepared to face, and spreading more awareness about it. And with this podcast, we hope to discuss some of the most taboo topics in medicine that are often not openly discussed. Today, we're diving into a topic that every physician hopes to avoid but must be prepared for: medical malpractice. Lawsuits are an unfortunate reality in medicine, and even the best clinicians can find themselves facing legal action. We've talked about the impact of litigation on healthcare providers before, but today we're coming back to this topic with a different focus: how to protect yourself before a lawsuit happens, and how to navigate the legal process if you're ever faced with one. To discuss this with me today, I have Dr. Stephen Cohen. Dr. Stephen Cohen is a board-certified colorectal surgeon, medical educator, and medical legal expert. As a medical legal expert, he provides clear, unbiased reviews for both plaintiff and defense attorneys, clarifying medical facts, causation, and standards of care. And we are very excited to get his expert opinion today on some of these hard questions that we have. Dr. Cohen, welcome to the show.
Thank you so much. I'm excited and happy to be here.
Yeah, thank you. I'm really excited to learn so much from you, but we ask everybody this question when they start the podcast: what's bringing you joy in medicine today?
Oh, yeah, that's a great question, actually. I mean, my joy in medicine today is seeing some of these surgical interns that don't know what field they want to go into. And maybe because of me, maybe because of the disease process, they decide that they want to go into colon and rectal surgery. So I see them
Yeah,
grow from not knowing anything, like I didn't know anything as an intern, none of us do,
yeah,
to all of
yeah.
a sudden now being a chief resident, taking care of, managing, and becoming board certified colorectal surgeons. That's great. And I really enjoy that.
Yeah, you're probably inspiring them and persuading them somewhat, right?
Well, I'll tell you a funny story. So, when I get the third year medical students, they like to come and watch me do colonoscopies, right? So
Yeah.
many of them have never done a rectal exam. And I make a
Oh,
big deal over that because you need to know. You don't, how do you know abnormal unless you do a bunch of normal things, right? So I had a
right.
one young third year medical student, and I'm always excited about the rectal exam, but not everybody is, and that's okay. And I
Yeah.
and I remember that this was her first rectal exam, and I told her, you never forget your first. Well, it turned out she wasn't even thinking of going into surgery. She is now one of our PGY3 surgical residents, and she just had a great time in the
Yeah.
surgical rotation. So that's a great feeling to turn on somebody into a field that I like.
Yeah, that's really awesome. And I'm glad you get joy from that. So diving into a topic of litigation, not so fun topic for, I think, clinicians specifically. But I know you're in colorectal surgery, but just generally thinking about what are some of the most common reasons physicians are getting sued today and how can they avoid litigation? So it's a general question.
Yeah, and that's a great question. I will tell you, because I'm board certified in general surgery as well as colorectal surgery. So I get asked to review a lot of different types of cases, whether
Okay.
it's gallbladder, colonoscopy, perforations. I will tell you that, having myself been sued 5 times, it doesn't mean you're a bad doctor. And I know it's easy for me to say that now, but the first time you get that lawsuit, you feel like you're the worst doctor ever. And that's a common feeling. But once you get into the system, and when we could talk about it, is that the most common reason that all of us get sued is bad outcome, right? It's not malpractice. I mean, none of us go into medicine to harm a patient, and we know that,
Right.
right? So
Yeah.
and this is what I tell the residents is that you have to remember is outcome of your patient
Yeah.
is not related to standard of care. It does.
Okay.
You can do everything right. Patients are going to have a bad outcome. You're going to get the post-op urinary infection. You're going to get the post-operative pulmonary embolus, even though you did everything to prevent it. Out of
Yeah.
every colectomy I do, if I take out a piece of colon and hook it together, 7 to 10% of the time, in the best of hands, it's going to leak. Is that a
Okay.
breach in the standard of care? No, it is a known complication. Having said that, the most common reason that all of us get in trouble is failure to recognize that complication and treat it in a timely fashion. So if your
Mm.
patient on post-op day 3 after a colectomy is dropping their blood pressure, they have a high white count, they're distended, you need to rule out the life-threatening illness, and that's where you may diagnose a pneumonia on day 3, but you still need to rule out the life-threatening illness. So it's failure to recognize a normal known complication, and then the patient has harm.
Yeah. That's very important. And I'm glad that you said that bad outcomes happen, but that doesn't mean you're a bad doctor. I think our physicians today, like, it because having been sued in the past, that it is really traumatic for every physician. And I've had that experience too. So
Right. And you have to, if you look at the big picture of medical legal
yeah.
cases, and attorneys know this, 90% of the time, all of us that get sued, they're going to settle the case. Right?
Yeah.
So
Yeah.
so there's no downside, put yourself in the position of a plaintiff attorney. 9 out
Yeah.
of 10 times, whether it's a good case or not, they're going to get some money out of it.
Yeah.
And there's no
And
downside to doing it.
if you get sued, yeah. What are some of the things we can do? So I know when we talk to our trainees and medical students, people I feel like who haven't been sued, they all talk about, communication,
Right.
documentation. How important are these things? I know they teach us, but how important are these things really?
Well, I will tell you because I do 50% plaintiff work and 50% defense work. And the
Yeah.
many times when I'm looking at a defense case, the
Yeah.
better documentation and communication, it's easy to defend.
Okay.
So I know we say good documentation, but you need to put in your document. This is what I teach the residents. You need to, you need to document like you're talking to the family or talking to the patient. Put your differential in and what are you doing to rule out, right? Patient is hypotensive. Here's the differential. This is what we're doing to rule it out. Getting your consults involved. Don't try to handle everything yourself. If you're a surgeon and you're having a lung problem, okay, you may be able to handle it. Get another doctor on board. There's no harm in that. Getting your pulmonologist, getting your infectious disease doctor. I recently reviewed a case where the colorectal surgeon was trying to treat a multi-system organ failure with one antibiotic. 3 days later, the culture came back that it wasn't sensitive to it. Then they got ID involved. The patient coded 6 hours later and died. So, get the specialist involved. There's no harm in that. Number one. Number two, document like you're talking. I think it's what are the post-op uh, typical fevers you get? Wind, water, walking, wonder drugs, the 5 Ws. go through all that and put that down. You can't say, well, I knew it wasn't a wound infection because I looked at the wound. Attorneys aren't dumb. Well, doctor, did you document that? If you didn't document it, this is an old cliche, but this comes up a lot. If you don't document, it didn't happen. That's the first thing. The second and third thing is, the second thing important is get the families involved. Talk to the families, talk to the loved ones. I will tell you that the most common driver of a lawsuit is not the patient. All right, I'm going to say that again because that happened to me.
Yeah.
The most common driver is not the patient. The patient bonds with you. You met the patient. Most patients like their doctor, and that's true. It's a year later there's a problem. They talk to a family member. You should sue that doctor. So, and that's a difficult one to prevent, but getting other people involved will help. And the third thing I will tell you, and I see this a lot, believe it or not, is disagreeing or fighting with your colleagues in the medical record. You can't do that. You may, call your cardiology consult that you think they need something. They disagree with you. You can't then go right in the chart. Cardiologists refuse to do something. I see that a lot in GI. Patient we think might have an upper GI bleed. They're stable. And somebody writing in the chart, gee, I refuse to do something. Don't fight with your colleagues. You can have a verbal conversation with them, but fighting in the chart, everybody's going to lose.
And you feel like you may be protecting yourself by doing so, but that's not
right.
Correct.
You're not necessarily protecting yourself by doing that because everyone's going to get named. And this has happened. I reviewed and I tried to defend the surgeon, but they wound up settling where the patient was about post-op day 7, became hypotensive, bright red blood coming out the rectum, had nothing to do with the surgery. I believe it was a pancreatic resection or something.
Yeah.
And they threw up blood. It was a classic upper GI bleed. It was in the middle of the night, of course. The surgeon calls the GI doctor. The GI doctor says, well, the patient hasn't had any blood yet. I'll come in the morning. He says, well, I think he needs it now. And this is all, the surgeon's writing this in the chart. 4 hours later, codes and dies. And the surgeon writes, I called the gastroenterologist to come in to do this procedure. He refused. Therefore, the patient died. Everybody got sued. So you have to really be careful about fighting with your colleagues and putting it down. Someone's going to read it.
Yeah. And a bad outcome happens. It could be standard of care. It could be that there was no standard of care. What are some of the red flags that you're seeing right away that you think you may get sued? Or what are some things that you can do afterwards? Is there something you can do?
Well, if you have a complication, I think it's important to recognize the complication, explain it to the patient. Again, you real time standing at the patient's bedside, examining the patient, looking at all the objective data, you are the best one to decide what the best thing for the patient is. But if there's a complication, you just need to acknowledge it and apologize to the patient. But there are certain things that no matter what you do, you may inevitably get sued. For example, retained foreign body. If I leave a lap pad or an instrument in the patient and I find it on day 3, yes, I'm going to apologize to the patient. I have to take the patient back to do the surgery, but that's usually a settlement. There are certain never events, and that's one of them, that no matter what you do, somebody's going to pay out for that. But I think as a big picture, as someone like me that has been sued, and I've talked to lots of other doctors that have been sued in the past too, it's not the end of your career, right? It's not the end of your career. We all have malpractice insurance, just like you have car insurance, right? A lot of times, even if you think you did everything right, but it's a bad outcome, it's a business decision for the insurance company because it's cheaper for them to make the payment. It does affect you because you will get reported to the National Practitioner Data Bank. But again, that's not usually a big deal. So, and I can real quickly, the National Practitioner Data Bank is a repository of any claim now, if any payment is made on your behalf, whether it's $1 or $1 million, it gets reported. The general public can't see that, but hospitals, when you go to credentialing, medical boards can see it, state boards can see it. I will tell you though, I've been listed on the National Practitioner Data Bank for 10 years. It hasn't affected my work or doing anything. You have to explain it, right? So the times I've been sued, it was bad outcome. This is what I did. I took the patient right back. They died anyway, right? So
Yeah.
again, it's really important, and until you get sued, you'll realize that outcome is irrelevant in standard of care. Because it's not fair to look at these cases in retrospect. You don't have a
Yeah.
crystal ball. I don't have a crystal ball. I do everything. And when I'm reviewing a case on the plaintiff side, I don't want to know the outcome. I look at it like, all right, this is post-op day 3. I'm standing at the patient's bedside. I know what the doctor knows. Here's the physical exam. Here's the laboratory work. What should happen? It's not fair to look at this in retrospect. And a lot of on the defense side, that's what they do. Oh, the patient died. Somebody must have done something wrong. And that's not always the case.
Yeah. And for doctors, I mean, apart from the money, yes, you do have insurance, but it feels somewhat personal, like it's more of like a personal thing, like a self-esteem thing and guilt and shame thing.
Right.
Yeah.
And absolutely. But there are resources, there are other people you can talk to. That's the problem, is because when you get sued, all of a sudden your defense attorney says, don't talk to anybody. You can't talk to
Yeah.
anybody. But there are resources out there that you can talk to somebody who's gone through it. And I'm happy to talk to people about it too, because I've been through it. And you're right, you're so emotionally involved that it's hard to think straight. And one of the things that I think is also important is, if and when you get sued, before you have your deposition,
Yeah.
it's really good to talk to somebody how to get through that. Now, your
Yeah.
attorney is going to try to walk you through it, to give you what kind of questions, because the attorneys go to school to twist your words to get the answer they want. But that's what they're trained in, right? And that's fine.
Yeah.
They're trained on that
Yeah.
on both sides.
Yeah.
But I have seen cases that I've tried to defend the surgeon, and how they answer in their deposition is not a good answer. So there
Yeah.
is help, if you look for it, to know, what are the questions? How are they going to spin it, or how are they going to twist it to get the answer that they want? So
Yeah.
rather than just listen to now the attorneys think they can coach you through it, but you're so emotionally involved, it's hard to think straight. And I get that.
Yeah, I was just going to say, since you mentioned it, what are some of the do's and don'ts? Like, if you are going to a deposition for a doctor, what are some of the do's and don'ts? Because
yeah,
emotionally challenging.
I would say, the biggest thing is you need to, you did the best you could, and you were working the patient up and doing the best you could. You have to continue to think, easier said than done, that outcome is irrelevant in standard of care. Why is that
Okay.
important? The one case I was talking to you about that actually went to trial, and I tried to defend the doctor because I thought he did everything right. It was a bad outcome. The reason that the jury came back and found against the doctor is because the very last question on his deposition, which was 2 years before, what was that question? The question was, doctor, knowing what you know now, would you have done anything different? And he answered yes. But that's not fair. That's not the right answer. You don't know the outcome. Outcome is irrelevant in standard of care. A better answer would be, no, I met the standard of care. The patient presented X, Y, and Z. I did this. This is a bad outcome. I'm going to do the same thing on my next 10 patients. Hopefully they won't have a bad outcome. But that's the only reason the jury came back and found against him. And that's disheartening because he did everything right.
Yeah, that is. And when so I think a deposition, just going through the process, it's very, very intimidating because the plaintiff attorney, it's almost like they are challenging everything that you're saying. And I feel like having gone through it, it kind of feels like it gets a little bit, you feel like somebody's confronting you on the thing that you did,
Right.
and you can get emotional. So how do you prepare for it in a way? Do you just state the facts of the case?
Right.
Because you, Mhm.
Yeah, so that's important. I mean, really, when you're getting deposed, if and when you get sued, you're kind of a fact witness. What did you did? What were you thinking? Right?
Okay.
So remember that a lot of doctors go into it thinking that I'm smarter than the attorney. I went to med school. I've been doing this for decades. That's fine. But remember, these attorneys are talking to an expert, right? So remember, no one can file a lawsuit until you have an expert witness on the plaintiff side to tell them that somebody fell below the standard of care. So they've had the conversations with an expert. So you're going
Okay.
into a deposition. Yes, the attorney's asking you questions, but he's already talked to an expert witness who's gone through this case every day, looking at all the objective data, maybe looking at the x-rays because they have all those records, and they're coming up with what were you thinking? But you just have to be a fact witness. This
Okay.
is how the patient presented. This is what I did. You don't have to necessarily defend why did you do what you did. In most cases, there was an indication for surgery. In surgical cases, it's interesting because, and I tell the residents this all the time, you're going to get complications in surgery. The only surgeons that don't get complications are either not doing surgery or they're lying. I mean, there's only two options. You're going to get complications. But
Mhm.
if and when you get a complication, the first question anybody asks you is, did the patient need an operation? And I know that sounds silly. I just got done reviewing a case where somebody was taken to the operating room for an enlarged appendix based on a CAT scan with, and I swear to God, no abdominal pain, no fever,
Mm.
no normal white count, came in for a different reason. And
Yeah.
and again, the only reason was a large appendix, no appendical lift, and that surgeon failed to look at the CAT scan from 3 months before that showed the appendix was the same size. During surgery, the trocar went into the inferior vena cava
Mm.
and 3-liter blood loss and big surgery, and you can imagine what happened with that. But again, did the patient need an operation? So you gotta be able to answer that question, yes. But again, you just tell the facts. This patient needed surgery. I stopped whatever. I stopped the Coumadin. I made sure the coags were good. This is what I did in surgery. But if you just state the facts, that's really what you're there for.
Sometimes a plaintiff attorney will ask, "Doctor, should you have done that instead? Should you have done this thing instead?" And again, the same question, "Doctor, would that have saved the patient?" And how do you answer such sort of questions?
Yeah, I think it depends on the case. I mean,
Okay.
it definitely depends on the case because
Okay.
remember, there is, physicians can rely on judgment to make their decision, right? As
Yeah.
long as your judgment is within the standard of care, that's fine. There's different ways to do everything, right? There's different
Yeah.
antibiotics we can give. There's different procedures for pilonidal. I can do a
Yeah.
subtotal colectomy. So as long as my judgment is within the standard of care, that's reasonable because there are different ways to do it.
Hmm.
Right.
And
So
if some,
again, yeah, you just have to I guess one example would be a colonoscopy perforation,
hmm
and the patient goes to the operating room and there's a big hole in the colon and there's some stool spillage. What are your options? Well, I can close it primarily, 2 layers. I could
hmm
do a resection, hook it together. I can do a resection, hook it together, loop ileostomy. I can do a
hmm
resection and do a colostomy. Any of those are within the standard of care. So
Okay.
if I decide to close it and it leaks, well, doctor, shouldn't you
Hmm.
have done something different? The decision I made was based on the patient was not hypotensive. There was very
Yeah.
little stool spillage.
Okay.
The bowel looked healthy. There was good blood, and I documented that in my operative note, and I closed it in 2 layers.
Yeah.
And if I did another procedure, that could have leaked as well, right? No matter what I
Yeah.
do. So you just have to state the facts.
Yeah. And I know you're not an attorney, but just based on your experience, if they ask you, you talked about not talking against other colleagues, they often ask you questions like if this person followed standard of care or if they did the right thing. What answers do you usually listen to in such conversations?
Yeah, that's a great question. So that has come up before too. So by the time you get deposed, you already know, and everybody already knows who is getting sued, right? So there is something called the empty chair defense, meaning
Okay.
if Dr. Cohen gets sued for something I do, but I think the GI doctor or whatever, I'm making this up, the GI doctor or ID led me down, or the radiology missed something and I can rely on the report, they didn't get sued. So now I'm in deposition. And I would
Yeah.
say, absolutely. Had the radiologist read this report correctly, there would have been a different outcome. They can't go back and sue the radiologist, right? So that's the empty chair defense. Does that make sense?
And as long as it's crossed the statute of
Right.
like
But
statute.
once they file the suit, they generally can't, and that's a question for the attorney, they can't go back and add names to the lawsuit.
Yeah. Okay.
That's why a lot of times when you may see, if somebody gets sued, the attorney will put John Doe or Jane Doe in case they want to add somebody. But again,
Yeah.
that's a question when you're talking to your defense attorney. Who are they suing? Let me tell you what happened. This is what I'm thinking. If the so they could say, no, say that. Say if they can't go back and sue the radiologist, you could say anything you want. Right?
Yeah. Okay.
Yeah.
Okay.
And that's an important, but again, there are some nuances with the medical legal world. Obviously,
Yeah.
every jurisdiction is different.
Yeah.
What happens in Virginia might be different in Georgia. So that's why you have an attorney, and they can go through some of those things with you. And most
Right.
defense attorneys are excellent. This is what they do, right? This is what they
Yeah.
do every day.
Right.
And generally, they'll be able to find a good expert to help you walk you through that and help guide you.
Right. Yeah. And you're right. You want to rely on your attorney for those questions. But yeah, when you're being asked questions, is it advisable to give extra information to try to defend yourself or just answer what's been asked?
It is just like in the movies. Just answer the question, because you'll
Okay.
throw something out that you think is important and you get down a rabbit hole that's not helpful. So it's just answer the question. And let me tell you something.
Yeah.
Having been through my own depositions, having done hundreds of depositions, I'm a talker. You cannot be a talker in a deposition. Just answer the question. And if you don't know, I don't know, or the one things that I do a lot, because you see especially if I'm an expert witness, I don't want to try to put myself in the mind of the attorney to see why they're asking me the question. So if they, ask me a question, I'll say, well, it depends.
Yeah.
Depends on what? Well, that gives me an opening to explain, like the judgment. There's different ways to do things. Either one could leak. So the least amount of information just to answer the question is always better. But again, you're so emotionally charged and you're mad and you're angry and you're the whole thing. It's a challenge.
Yeah. And one of the things is also like you don't want to appear like arrogant or, like I don't know if you agree, but you still want to appear that calm demeanor, like if you feel like, yeah.
Right. And that's hard. There's no doubt. But so the other thing is, and I know when I'm doing a deposition or when I'm either on the plaintiff or the defense side, sometimes it's not actually what you say, but it's how you say it. Because I know
Okay.
I know the other side attorney is looking at me thinking, what is he going to look like in front of the jury? And if I can
Yeah.
make him look arrogant, like he thinks he's the smartest doctor in the world, we're going to trial. So I
Yeah.
always tell my side, whatever side I'm on, I've been on both sides. If I do a good job, this case either goes away or they're writing you a check. Because
Yeah.
if they want to go to trial, that's fine.
Yeah.
But it's much easier to remain calm, cool, and collected when you're the expert witness versus the one getting sued. But
Yeah.
again, talking to other people that have gone through it, talking to your attorney, getting an outline of what questions they're going to ask you and what you were thinking, that's really and just sticking to the facts of the case.
Yeah. And you talked about one mistake. Can you think about any other mistakes that you've seen physicians make in depositions?
No, I mean,
And
I think
it's,
those are the most important things. I mean, either bringing up, yeah, other things or, um, I have seen a lot of doctors say things that are not true in medicine.
okay.
Which are, you got to remember when you're under oath, there's other doctors going to read what you say, so you can't say dumb things. But I've seen doctors defending themselves say dumb things. I've seen doctors on the plane, trying to defend themselves on both sides. I mean, I had a doctor recently in a trial that went against him. It was a patient who was post-op hernia repair, who the 3 days before discharge started spiking fevers. His white count went 8,000, 12,000, 15,000, 22,000 with a left shift and became acidotic. He's morbidly obese. The physical exam was not remarkable. Yet in his deposition, he said, I don't look at the labs. Labs don't matter. The physical exam is the most important thing. Well, the problem with that case is two medical doctors, infectious disease and a hospitalist, wanted to get a CAT scan. The surgeon said, no, let the patient go home. What do you think happened? His anastomosis fell apart 24 hours, septic, he died. But to say we don't look at the labs, you didn't learn that? You look at the lab. That's why we get the lab. So saying things that are not factually true will not help your case.
Yeah, that's true. Yeah. I mean, I think you don't want to invest your emotions, but you want to be humble. Some humility. Yeah. I
Yeah.
remember my attorney told me once that there was a doctor who came up wearing shorts and he to the deposition and he was like, I didn't do this wrong. And so yeah, didn't go well. But yeah.
No, you have to be humble. You have to, but most of that's the outliers. I mean, most doctors are doing the best they can. You're taking care of a patient. You don't want to harm the patient, but the medical legal world is out there, and many physicians, and I don't remember what statistics are, but a high number of physicians get sued. Doesn't mean you're a bad doctor. you know, um, Being honest in your deposition of the medicine and the facts of the case is going to help you the best.
Yeah. And so most times when you get sued, I think there's a discovery process where you have to answer some questions and you go through deposition. And depending on state, you said after that, most lawsuits go into settlement, or what happens if it goes to trial?
Yeah, so the statistics are 90% of the time the case is settled. Now that still may be after deposition.
Okay.
Normally what happens is you get served the lawsuit, you go through your 5 grievous stages, those grieving
Mm.
everything. And
Yeah.
normally you're going to get deposed. The surgeon that gets sued or the doctor that gets sued is going to get the deposition of the facts of the case. From
Okay.
that point, and again, jurisdictions are different, they find before the case gets filed, generally the plaintiff attorney has to find an expert witness to say, yes, this doctor fell below the standard of care, then it's able to get filed. But
Okay.
generally, the case isn't going to settle usually before you get deposed, unless it's
Okay.
something like leaving a lap pad in, cutting off the wrong leg, taking out the wrong kidney. Those are not defensible, and everybody knows that. But the
Yeah.
most of them are defensible because you didn't do anything wrong. You'll
Mm-hmm.
get deposed, and then the plaintiff expert gets deposed, and then the
Mm-hmm.
defense experts get deposed. So when I'm reviewing a case for the plaintiff side, I get the benefit of I've already seen the chart. I already determined somebody fell below the standard of care. Now I get to read their deposition. What were they thinking? So when it comes to my
Mm-hmm.
deposition, I like to point out, this patient had a change in clinical status, objective data that there was a potential surgical problem. The patient shouldn't have been sent home. They should have had the CAT scan, right? So I have the benefit of that. Fence expert is reading
Mm-hmm.
mine and tries to defend the doctor. It's like, I know Dr. Cohen said, but we don't care about labs. So that's kind of how it plays out. And then the attorneys during this time are either trying to settle the case or they decide they're going to trial.
Yeah. And after it goes to trial, then what happens if you lose the trial? I guess I'm trying to see what's the worst that can
Well,
happen to the
so
doctor.
statistically, the odds are in your favor all the way across the board. 90% of the time it's going to settle. The worst thing will be you're reported to the National Practitioner Data Bank. I don't think that's a big deal. If you get there a lot, maybe, but it doesn't generally affect much.
Mm-hmm.
If and when you go to trial, 87% of the time, it will go in your favor.
Okay.
If you go to trial, 87% of the time, even if you did something wrong, it's fine. I mean, I've been on the plaintiff side where I thought they did something wrong, but the jury doesn't find that. Remember, the whole system, it's not really a jury of your peers, right? This is 6 or 12 individuals with probably very little to no medical background. It's not their fault. They have an average 8th grade education level of medicine. Again, not their fault, but that's the pool of the jury. And look at it from their perspective. They are being heard from two board certified experts, have been doing this for decades, big CVs published in the literature saying exactly the opposite. One says they met, one says they didn't meet. How are they supposed to figure that out? It's hard for them, right? I mean, so the way I look at it, hate to say this, the truth doesn't always matter in a court of law. It's a game for all of them. For the attorneys, it's a game. If they can win on a technicality, they're going to win on a technicality. It's, from a jury standpoint, do they like this expert? Do they bond with this? Who do they like better? And that's really what it comes down to. Sad to say, but most of the time, it's going to go in your favor. And it's very difficult, even though you hear it in the news of all these plaintiff cases, that's a very small percent. Most cases, if and when it goes to trial, goes in favor of the doctor. Because again, this is what I tell my friends, and I've defended lots of doctors. Don't, look, you look at the jury. I did the best I could. This is what we were dealt with. This is a bad outcome. I know the patient either died or has a colostomy, but I did the best I could. Most juries don't want to go against the doctor. That's my gestalt from doing this for a long time. But if it's it's a serious negligent case, then the doctor will lose, but most of the time it goes in their favor.
Okay. That's good to know. I think for anybody who's listening and who has been sued, just to remember that end point in mind. But it still takes, I think the whole process is very long drawn. It takes several years.
It is very annoying. It's not like medicine or surgery. I like surgery. It's quick, right? You got an appendicitis, we're taking it out. Nothing is quick. Nothing is quick. The trial I just got done with started 5 years ago. I mean, that's when the lawsuit got filed. 2 years before that was the incident. So 2018 is when this problem was. Here we are in 2024, 25 with a trial. Nothing goes quick. It's this motion, it's that motion, it's this motion, it's this thing, it's this, that. It's annoying, but and that's, if and when you're the one getting sued, it's very annoying and stressful. And I get that because I've been through the same thing and my cases took forever.
Yeah, it's like this knife hanging over your head. And how do you, like in terms of other mistakes you talked about, who can you tell or not tell? Like who can you talk to during this long drawn time?
Well, you definitely shouldn't talk to anybody involved in the patient, for sure.
Okay.
But certainly you can reach out to other colleagues, or the attorneys will be able to help guide you who you can talk to. Jurisdictions are a little bit different to get help about those types of things.
Yeah. Okay. But I think it's still okay to talk to, if you're not talking about the details of the process, like it's okay to get some emotional support,
Correct.
right?
Emotional support you can get from anybody. Absolutely. As long as you're not talking about the details of the case. Absolutely. Yeah. And there's plenty of doctors that are out there that have been through it like me. And there's also, do you know Dr. Gita Pensa?
Yes, she's amazing.
She's awesome, right? So I met her.
Yeah.
Same thing. She helps guide individuals through the same thing. So there are resources that maybe you can link to her in this podcast because she's helpful. I can be helpful to try to get you through it because we've been through it. And once once you've been through it once, it's easy the second time around, because again, when you did nothing wrong, you did everything you could, it's a bad outcome. And we're going to get bad outcomes. The problem with medicine, the way I've seen it for the last 30 plus years, is patients want a guarantee. And there is no guarantee in medicine. There's no guarantee in medicine. And the older I get, when I consented a bunch of patients this morning for surgery. These are the complications. And I go through my speech with everybody, especially in surgery. There are 6 things that can potentially happen in surgery. I don't care if this is a colectomy for cancer or this is a hemorrhoidectomy. It's bleeding. It's infection. I can make you worse. I can injure other organs. You can have anesthesia complications, or you can die. Those 6 things cover you for any potential complication. What happens is you're going to do a surgery you've done 100 times or take care of a patient with a certain illness, the same that you did the last 100, and there's a rare complication that you didn't tell the patient. And that's what they latch on. Did you tell the patient they're going to have this rare complication? No, because I've never even heard of this complication. That's happened, right? So those 6 things I put on every consent form: bleeding, infection, I can make you worse, I can injure other organs, anesthesia complications, or you can die. And that somewhat protects you. Even though we do informed consent never protects you from getting sued. It doesn't matter. Doesn't matter.
Yeah.
Yes, you have to do an informed consent. Of course we do. But you could still get sued, even though on the consent it says you can die, right? Because they'll say, well, if you did X, Y, and Z, they wouldn't have died. So you have to do an informed consent. It doesn't protect you in a court of law.
It does. And in hospital-based work, there is no consent, right? People come to the hospital all the time, and you can't sign a consent.
Right. Right. You're just treating that. Well, I think there's a general hospital consent for medical care, but but again, it doesn't protect you, right? When you sign in, like in our hospital, you're at a teaching hospital. You sign to let the doctors do whatever they think is right. Okay, yeah, you're doing whatever. Of course, you're doing whatever you think is right. We're taking care of you, but it doesn't protect you. You can't say, look, there's an informed consent. You can't sue us. No, it doesn't work like that. So.
And I've learned the hard way. I take care of kids and parents are usually scared, but I still tell them everything. And one of my residents and medical students was kind of freaked out she's like, you're kind of scaring the parents. But
the older you get, the more scared I want you because anything can happen, right? That one dose of antibiotic can give you C. diff and you can wind up with a colectomy or Stevens-Johnson syndrome. We've all seen those rare things, right?
So you want to tell them everything. Yes. Is there something you should not particularly say to patients or families, like sorry, or, something that you can think of from a legal standpoint?
No, not really. Well, again, the only thing I've seen that I wouldn't do is I've seen other doctors do this. If you're seeing a patient for a second opinion, or you're seeing a patient of a complication of that somebody else did, don't throw that person under the bus. For example, and I've reviewed a case like this, and it drives me crazy. A patient had a incisional hernia repair, all within had abdominal pain, distension, documented incisional hernia with a bowel obstruction, had surgery by a great surgeon. Everything was fine. Went out of town, not far, still stayed in the state, but traveled, had a problem within, 6 months, had a recurrence of the hernia, which can happen. That second surgeon said the first surgeon did something wrong. You should sue him. Don't do stuff like that. Why would you do that? Right. So I reviewed the case saying outcome is irrelevant in standard of care. This patient needed surgery, had a great operation. This is a known complication of a hernia repair. I've had a lot of recurrences. Doesn't mean they did anything wrong.
And sometimes the families will kind of lead you onto it too. They will say that they weren't happy with whatever care was provided at the other hospital or primary care office. So we should never encourage that. Do you agree? Yeah.
Well,
Like,
100%. I mean, because if you look at it from a patient's perspective, and both of my parents have been in the hospital, none of us like being the patient. I get that, right? The care, when you see it from the patient side, you go, ugh. But it is important to not throw the other providers under the bus. You can acknowledge, I'm sorry you went through that, but don't get involved with you should sue them or I have a name of an attorney because I've seen that before, or they should have done something different because you weren't there at the time of the event. You didn't see what happened, right? You haven't looked at everything, so it's not fair for you to do that for the other providers and for the family members.
yeah, that's very important. I think we're almost getting towards our end. Is there any advice? And you've said a lot of great things, but words of wisdom for a physician who has been sued, has never had this before, some words of encouragement, I would say, that you have.
Well, I think the words of encouragement are many of us have gone through what you may go through in the future.
Mm.
Number one. Number two, it is not a life sentence. It doesn't mean you're a bad doctor. Your career is not over. It's, there are support systems to help get through what you're going through, and you will be fine on the other side. And you shouldn't really change what you do based on one lawsuit, especially if you've met the standard of care, which most of us feel like we do when we've had a bad outcome. So the problem is, you remember, you're only as good as your last case, right? So
Yeah.
if you think there's something you didn't do or somebody said you should have done, don't go above and beyond of doing a bunch of unnecessary things. That's not going to make a difference.
Yeah.
So, but
And you
again,
said
it's
this,
easier said than done.
you said the second time is easier, but did you kind of feel a little bit of distrust towards the families when you're getting sued once, or no, not really?
No, I mean, again, in all of my cases, it wasn't the patient that drove the lawsuit. So the first patient who sued me,
Yeah.
she called the office 6 months later to try to get an appointment with me. Well, it's flagged in the chart that she's suing me and the practice, right? So my practice manager got on the phone and said, "You can't come see Dr. Cohen. You're suing Dr. Cohen." She said, "I'm not suing Dr. Cohen. I love Dr. Cohen." Well, the attorney put my name on it without even telling the client. That suit wound up getting dropped. But that kind of stuff happens all the time. And most patients don't want to sue their doctor
Yeah.
in
They don't
general.
want to.
They don't want to. They don't want to because they know you saw them in the office, they bonded with you, you signed up for surgery, or you've seen them every day taking care of them. Um,
So
so
you're
that
saying it's driven by external factors, or is that what you're trying to say?
most lawsuits are driven by the family members, spouse, children, other factors that are driving it.
Yeah. Okay. That's good to know. Is there anything that we haven't talked about today that you would like to mention before we close this? It was really helpful, though, this conversation.
No, I think we kind of hit all the highlights. It's, I think the bottom line is that it's, you're still a good doctor if you get sued. The
Yep.
odds, even if the case settles, means a lot of this is taken out of your hands. It is a business decision from the insurance company, and it's generally, listen to the people uh, that have been through it before. The attorneys do this every day. They talk to a lot of doctors that have gotten sued. The insurance companies are used to it. They know every year they're going to have to pay out a certain amount of claims. And to them, it's a business decision. So you can't take it emotionally because it's you. And again, it's easier said than done. But remember, it's a business decision. There is help through a lot of different resources that you can get. And you will be okay at the other end.
Yeah. Thank you so much, Dr. Cohen. Before we end, I want to leave the audience with a poem. It's just a tradition on our podcast, but it's just for 1 minute. If you'll stay with me for that. It speaks to resilience in the face of hardship. In medicine and litigation and life, we face moments that threaten to, harm us. But the poem is called The Thing Is by Ellen Bass. It just captures the weight of the moments. To love life, to love it even when you have no stomach for it, and everything you've held dear crumbles like burnt paper in your hands. your throat filled with the silt of it. When grief sits with you, its tropical heat, thickening the air heavy as water, more fit for gills than lungs. When grief weighs you down like your own flesh, only more of it, an obesity of grief. You think, how can a body withstand this? Then you hold life like a face between your palms, a plain face. No charming smile, no violet eyes, and you say, yes, I will take you. I will love you again. Thank you, Dr. Cohen, so much.
Thank you so much.